Welcome. We've all been there. In the OR, staring at the films of an unstable proximal femur fracture. It feels just a little too low for a short nail, but you're really not excited about the added time and blood loss that comes with a long one. Well, in this explainer, we're going to dive deep into the evidence for intermediate-length cephalomedullary nails and really explore how they might be changing the game for these exact cases. All right, so here's how we're going to break it down. We'll start with the clinical problem and that classic implant debate. Then we'll introduce the intermediate nail as a specific solution. After that, we'll get into the comparative evidence, define some clear indications for its use, and then wrap things up with some key takeaways and surgical pearls for your practice. So first, let's set the stage. We need to really understand the clinical context, the intensifying challenge of these fractures, and the long-standing controversy that surrounds which implant to choose. Look, it's no secret. As our population ages and osteoporosis becomes more prevalent, the clinical burden of these fractures just keeps growing. These aren't simple injuries. They dramatically impact quality of life and are tied to some pretty significant patient morbidity and mortality. This brings us to the classic debate, short nail versus long nail. On one hand, short nails are great for operative efficiency, right? But they do carry the risk of toggling and varus collapse, especially in those wide canals or if the lateral wall is incompetent. On the other hand, long nails give you that enhanced stability, but it comes at a price. More OR time, more blood loss, and all those technical headaches like freehand distal locking and potential femoral bone mismatch. So, given the very real limitations of both short and long nails in certain situations, it makes sense that a new solution would pop up. Let's see how this intermediate length nail really aims to bridge that gap and maybe, just maybe, give us the best of both worlds. Okay, so what exactly is an intermediate length cephalomedullary nail, or ILCMN? Well, it's typically about 235 to 240 millimeters long, and its whole design philosophy is about a biomechanical compromise, giving you more diaphyseal stability than a short nail by bypassing the isthmus, all without the technical messiness of a full-length long nail. Now let's really dig into the biomechanics here, because this is where it gets interesting. From a surgeon's perspective, the ILC-MNIN is designed to be user-friendly. It uses the same targeting jig for simple distal locking, but the real secret sauce is its length. By getting past the isthmus for a better diaphyseal fit, and by separating the stress points at the nail tip and the distal screw, it's engineered to cut down on those midfemoral stresses and, hopefully, lower the risk of a subsequent peri-implant fracture. All right, so that's the theory, but what does the actual clinical literature say? We're now going to critically look at the existing studies, zeroing in on those that directly compare intermediate nails to their short and long cousins. When you start sifting through the retrospective literature, a few key patterns emerge. You see studies like Womble et al. And Thum-Young-Kit et al. That consistently show ILCMNs offer some pretty significant intraoperative wins over long nails. We're talking less OR time and less blood loss, without a big jump in major post-op complications. And what's interesting is that Albaz and his colleagues even noted a potential benefit in reverse oblique patterns, with lower cutout rates than short nails. And this chart illustrates one of the main findings from that Thum-Young-Kit study perfectly. Using an intermediate nail led to a statistically significant drop in average surgical time, from 92 minutes for a long nail all the way down to 68 minutes. That's a real difference. And that same study documented this, a major decrease in intraoperative blood loss. It was more than cut in half, from 168 milliliters with a long nail to just 80 with an intermediate nail. And we all know, for this often frail patient population, that is a clinically huge deal. So what does this all boil down to for patient outcomes? Well, the good news is that these intraoperative benefits don't seem to come with a trade-off. The evidence we have suggests that for unstable fracture patterns, ILCMNs have pretty comparable rates of non-union, malunion, revision, and even mortality when you stack them up against long nails. Okay, let's translate this evidence into practice. We're going to lay out the specific clinical scenarios that make up the absolute and relative indications for reaching for an intermediate length nail. So the number one absolute indication for an ILCMN is a low intertrochanter fracture. Let's define that as extending more than 3 centimeters distal to the lesser trochan, in a patient who already has a distal intermedullary implant, like a stem total knee. In this case, a short nail just isn't enough biomechanically, and a long nail is physically blocked. Just think about this very common and tricky clinical problem. In this exact scenario, the intermediate length nail isn't just a good option. It's often the most logical, and sometimes the only viable intramedullary fixation solution you've got. Beyond that absolute indication, there are several relative ones where you can make a really strong case for the ILCN. For low intertrochanteric fractures without any distal hardware, it gives you stability while dodging the morbidity of a long nail. For those tricky reverse oblique patterns, it might just give you a lower risk of cutout than a short nail. And in fractures near an unstemmed knee replacement, it helps avoid creating a stress riser right next to the femoral component. And we can go even further. In fractures where the proximal anatomy is compromised, think an incompetent lateral wall or really wide dorsal calo-canal, that enhanced diaphyseal fit you get from an ILSCMN can provide critical mechanical stability. It helps resist the toggling and varus collapse we sometimes see with shorter constructs. All right, let's distill all of this down into some practical take-home points that are relevant for both how you plan your surgery and how you execute it in the OR. A huge advantage here is that the surgical technique is basically identical to putting in a short cephalomedullary nail. The entry point's the same, the emphasis on holding that reduction is the same, you're still aiming for a good tip apex distance, and you're using the targeting device for your distal locking. The goal, as always, is getting adequate canal fill for rotational stability. So, how do you apply this to your practice tomorrow? It really comes down to identifying the right patients and the right fracture patterns. The ILCMN should be your go-to for those low IT fractures sitting right above existing hardware, and it's definitely worth considering over a short nail for reverse oblique patterns or in patients with that challenging anatomy, like a wide canal or a blown lateral wall. Okay, let's wrap this up. Let's summarize the role of the intermediate length cephalomedullary nail and think a little bit about what the future might hold for this implant. In a nutshell, the ILCMN should be seen as a valuable third option in our toolkit. It's not a universal replacement, but it's a real problem solver for specific, challenging fracture patterns. It gives you the surgical ease of a short nail with stability that gets close to a long nail, and it has clear intraoperative benefits with comparable post-op outcomes in the right situations. Now, while the retrospective evidence we have is compelling, the orthopedic community really needs higher-level data. What's next are future prospective randomized controlled trials. That's what we need to definitively establish if and where this implant is truly superior and to really solidify its place in our evidence-based practice.